Alright, continuing our lectures on chest pain and acute coronary syndrome. So, non-classical MI symptoms. Nearly half of MI patients present with symptoms other than chest pain, making it a clinical and a challenging diagnosis, a clinical challenge. The common symptom equivalents. So these equivalents are actually to bear in mind that they might be equivalent of a chest pain, but even though that the chest pain is not present. So a patient coming in having dyspnea or nausea, lightheadedness, or diaphoresis is something to put at the back of your head that this patient might need an ECG. Now, dyspnea being different from the other equivalents, being that it's the mostly associated symptom with increased risk of cardiac death. So it's the most severe and the one that you should be taking care of the most. Clinicians must maintain suspicion for acute coronary syndrome even without chest pain to ensure timely diagnosis. So that's what we're talking about. Now, even sometimes some patients can come in and have abdominal pain, and this abdominal pain can be even relieved by antacids. But even though this is actually an acute coronary syndrome, so bear this in mind. And especially this happens in older adults, menopausal women, and so you would send them for an ECG. Now, palpitations, new onset palpitations may reflect myocardial ischemia, increasing risk of arrhythmias and cardiac complications. Tachycardia elevates myocardial oxygen demand, potentially triggering ischemic cardiac events in vulnerable patients. Now, as we said, menopausal women, that they could have a different presentation of acute coronary syndrome. It happens in pre or early menopause, and the pain is unrelated to exercise. It's not relieved by rest or nitroglycerin, and it's relieved by antacids. They can present just with palpitations without chest pain, and the chief complaint could be fatigue. They can have associated symptoms like nausea, emesis, jaw, neck, back pain, so radiating to these areas. Or they could just have not any chest pain and just have pain in those areas. Now, it's bear in mind that diaphoresis is more likely to happen in men rather than women. The risk factors for coronary artery disease. Now, an age over 40, of course, is a major risk factor. Gender being males more common than females. Hypertension, tobacco use and smoking, diabetes, truncal obesity, of course, and family history of coronary artery disease increases the risk significantly. Now, also, cocaine use and highly active antiretroviral therapy also increases the risk of atherosclerosis and coronary artery disease. Now, it's important to bear in mind that these risk factors actually predict which population is at highest risk of developing coronary artery disease throughout their lifetime, but not particularly in the presentation of a patient. So whenever a patient comes in and has chest pain, say you have two patients, one with risk factors and the other without risk factors, having risk factors does not mean that at this particular moment that the patient with risk factors is more likely to have a current ongoing acute coronary syndrome. You have to actually rule out acute coronary syndrome in both. Now, the likelihood of having acute coronary syndrome depends on the history. So if the patient complains of radiating pain to the arms or exertional chest pain, this makes the likelihood of acute coronary syndrome very high. Now, symptoms like dyspnea, diaphoresis, nausea are also associated with acute coronary syndrome, but less likely. Sharp pain or sharp chest pain, pleuritic in nature, and changes with position is the least likely associated with acute coronary syndrome. However, it does not exclude it. Now, on your physical exam, Once you do your vitals, you might see hypertension or hypotension. You might see tachycardia or bradycardia, whichever one. Now, once you auscultate the heart, you could hear an S3, and that would be because of the ventricles not pumping, because of the damage that has happened to the ventricles. So the patient is going into fluid overload and pump failure. He can also go into having an S4 because of these stiff ventricles and hypokinesis that's happening, and the atria are trying to contract against the stiff ventricle, making this S4 happen. There could also be a diminished S1 because of the stiff ventricles. The valves, or the mitral and tricuspid, do not close as efficient. There could be a split in S2 because of the delay in either the component A2 or P2, because again the ventricles, either the right or the left ventricle, are delaying in their action and therefore delaying the closure of the aortic and pulmonic valves. Now you might also find pulmonary findings. You could auscultate the lungs and you could find pulmonary crackles. So you should always look for that, because that might mean that the patient is going into congestive heart failure due to the myocardial infarction. Now it's also important to have in mind that chest wall tenderness does not exclude an acute coronary syndrome, because it was seen that some patients who had acute coronary syndrome also had chest wall tenderness associated. So even though it's mostly linked to musculoskeletal pain, it's not a definite exclusion. Now, as we said, relying on that the chest pain responds to nitroglycerin and antacid does not reliably distinguish cardiac from non-cardiac causes, because as we saw, that some chest pain could respond to nitroglycerin and could respond to antacids and still mean that this could be an acute coronary syndrome. So there's a big overlap. Limitations of therapeutic response. As we said, symptom relief should not be solely used to diagnose or exclude acute coronary syndrome due to the overlap, and therefore you should always rely on the overall picture through the history, physical exams, and sending your investigations and your ECG, and also having your biomarkers and troponin titers. So the key takeaways is that acute coronary syndromes vary widely between patients. There are non-classical presentations, there are classical presentations, and some of them are more likely to be acute coronary syndrome, some are less likely. Risk factors do help, but they do not tell us at the current moment that this patient does or doesn't have acute coronary syndrome. There is some diagnostic challenge, so we rely on the whole picture, the history, the physicals, and of course your tests and labs. Thank you for listening.